physical. This is a good thing. What I can recommend is that our results get better when we use tests for closing this way. But the test, we should not take a large test and put inside. It doesn't work. You have to take a small piece of the test. First, close all holes around the dura, which is open, with fiber screws. And when you have closed every corner with tiny small tests, then you can put larger tests over there, and then you can do it. This is my experience in this case. But this is a video intrapontific extension for normal. I had no idea. Look, we started this tumor coming from here, but mostly intradural and here. This is the first thing you see in the history of medicine. As we operated, I decided to use it from posterior because there was a big intrapontific, and I said, if I go in the midline and I open the stent, which was a good result, and it was exactly the same idea. I decided to do it in this way, and you can see that I have here already the clitoris. Here, it is open, and now you will see the basilar artery. This is the basilar artery. That's basilar artery, and that is the hole, and this is the post-operative MRI. Demonstrated the removal of the tumor, and here, in this case, the patient has no additional deficit, even recovered. That's the patient after the surgery. Taking short time after the surgery. Of course, we kept here for a few days, and the surgery is not available, and although the eye function was intact, and we're very happy that I mentioned this, but it's a very exceptional, rare situation. It is not a case we can live in the next 10 years or 20 years. So we are talking about rare tumors and rare surgery today, and therefore I show you such exceptional cases. Now, the other topic is arachnoidal lymphangitis. It is more frequent than you believe. I have operated around 40 cases of arachnoidal lymphangitis in this long time, and we published from 1990 to 1996, 12 cases, I think, in the Journal of Surgery. And in arachnoidal cells, they create different symptoms. They compress, particularly several aids, create a vestibulocochlear dysfunction. Very rarely, in one case, we have a facial palsy, and it is very, very important that we remove the digit wall. It's very important, and there are two types of digits. One is like edgar, that the digit wall is adherent to the brain other, or not adherent. So if they are very adherent, in one case, and on 40 cases after, I was relatively radical. I created deficits. And that was for the big learning case that I said I have to do this time. And you can see that in our, it was the first case, 1996, we have published. And they, of course, they can extend in different directions, and they have also the two cases with extension internal auditory canal, and they can extend outward, downward, not so interesting, but the clinical symptoms are vertigo, hearing loss, ataxia, headache, and tinnitus, and the symptoms are peripheral numbness, swallowing, and as I mentioned, in one case, 7 nerve problems. up to decompression, passive movement, and as you see, one patient is increasing morbidity is not following disturbance and action, very accurate for a patient with, we had one patient with a recurrence, we had to operate. Next, operation cholesterol granuloma. Cholesterol granuloma created in the pelvic bone. And as you see here, they can extend also into the GI, they can extend in every direction. And very important is that the carotid artery is open to all. And the cranial cavity sometimes up to abdomen. And here, in this case, I use the material approach. You have to, there are some techniques, but recommended in their history, put just tube to the cyst and thread. This doesn't work. There are also some regarding but I show you my measure technique is, in this case, as you see, this is surrounding and guideline. Take the meningeal artery and here, and that is not temporal approach. That is the parameter node, and that is your navigation. It's better as any navigation system. You don't need here, and you need the intraoperative navigation. Shows the position of the meningeal artery. Meningeal artery, you have to follow it and transect it here. This is the little bottom, and then you take the lamp to it. You know, just posterior to the middle. This is the alveolar nerve, the third branch of the transcriptional nerve. Here, this is the third branch. So then, when you start to drilling over the carotid artery, you must be careful not to destroy the carotid artery. This is the carotid artery when you go and medial caudal to the carotid artery. You can see here also with the navigation the position of the carotid artery. And here, that the tumor is, the cholesterol granuloma is open. And here is the carotid artery. Here. And then we start to we would like to remove the capsule to avoid recurrence, so that you take the diamond drill and then you can drill the wall inside the wall. So, and then of course you can put fat on this or fat whatever and then go. So this is my favorite today approach, and almost every month I do keep cases like this for removal of this. Another thing is hematoma of the internal auditory canal. I have here only 3 cases in Australia, very rare, and they are very aggressive, growing into the nerves. So in this case,